Welcome back. Today we're going to study the physiology of the heart and try to put into effect some of the practical aspects of how this wonderful mechanical pump works. By way of review, remember now that we have this very small, very efficient pump pushing blood, a very viscous liquid, through some 50,000 miles of vessels, both gross and microscopic, and beating at a rate that is able to put out some 20 quarts per minute at rest and much more during exercise, which amounts to about 1.5 million gallons a year, year after year. During an average cycle, let's say with a cardiac rate of 60 beats per minute, the rest period is less than a second. You can increase this factor by factors of 5 or even 8 times as much under conditions of extreme stress, and the heart is up to the job. There's something called cardiac reserve, which is enormous. This is a ratio between the maximum cardiac output and the resting output. And this is the figure that I mentioned, some 5 to 8 times the volume that can be delivered over what's delivered normally. Now, before we get into the actual physiology itself, there needs to be just one more definition before we get started, and that's the difference between systole and diastole. And it's important to understand when we talk about those two words, we're talking about the ventricles. When the heart squeezes to make its pumping motion and pump blood out, during the active time of squeezing, the high pressure propelling of blood out the major vessels, whether it's the pulmonary or the aortic vessel, the active squeezing is called systole. That's the high pressure end. Diastole is the relaxation that occurs during filling again. Now, of course, the atria both have their own systole and diastole, which are at a different timing than the ventricles. But unless we say it specifically, when we refer to systole and diastole, we're only talking about the ventricular systole and diastole. So let's talk a little bit about the physiology again and go back to reviewing this slide of the heart. We have our right and left sides of the heart and the atrium, which is very appropriately named as the waiting room. Blood flows in to the atrium and then flows in by being pumped into the ventricle. But the atrium is not necessarily very efficient or powerful. And if we lose atrial contraction, which we can do in disease states, the efficiency of the heart is only dropped somewhere up to about 30%. So, for example, there is a disease called atrial fibrillation. Fibrillation means uncoordinated contractions of the muscle. Instead of the atrium giving a good, solid, coordinated pump, it may wiggle like a bag of worms and really not pump anything. There's something called ventricular fibrillation, which is not compatible with life. That's what we often call a cardiac arrest, and that's what's happening when you see them put the paddles on somebody and shock them. They're trying to convert that fibrillation, the worm-like motion, back into a real contraction. In atrial fibrillation, patients can live for years with it. No effective blood is being pumped. It's merely being passively drained into the ventricle, either by gravity and or some suction that's created as the ventricle expands. So this part of the cycle, whether it's the right or the left atrium, means that we get extra efficiency by having good contractions, but not necessarily important to life or survival. We're going to talk about that more in just a minute. I want to move on to the conduction system, because in the conduction system, we have a lot of places where absolutely critical pinpoint timing is involved. As I told you, about 1% of the mass of the heart is designated as an autorhythmic, self-exciting type of fiber, one that inherently will make itself discharge electrically, and those electrical discharges will make the heart contract. And what happens is it starts up here in the sinoatrial node and propagates, meaning every millimeter along the way discharges the next millimeter. So the electrical wave passes along in a coordinated way down the atrium and into ending up here at the atrioventricular node. This node then picks up the beat and moves it on through the atrioventricular bundle of His. His was a man who discovered this physiology and got his name stuck onto it. You're going to hear a lot of those eponyms during this course. And then everything divides pretty systematically and moves along the rest of the cardiac muscle to make it contract. Now, again, evolution has done an extraordinary thing. It's made a little roadblock here. Remember what's happening. If you look at the atrial contraction, the electricity has come down very fast, but it takes a few microseconds for the muscle to respond. The ventricles would really like to have all the blood in there that it can get before pumping out, and I'll explain why. And so it takes a little extra time for the response to make these atria contract and then to get the blood into the two ventricles. This roadblock right here at the AV bundle is the one that does it. It slows conduction just long enough so that the electricity is held up, just like a traffic jam on a highway, and these atria have the ability to empty themselves completely into the ventricles. The ventricles then go ahead, fill, and do their ventricular ejection. There are disease states in which these fibers get blocked. These are called bundle branch blocks. You have a right and left bundle here because they're bundle of nervous tissue, or myofibers of Purkinje is what they're actually called, another physiologist who attached his name. And something that happens to the myocardium, for example, a heart attack, instead of striking the muscle out here, it might strike the muscle right here and not only injure muscle, but might injure the conduction fibers. And that patient would have what's called a bundle branch block. If the block is severe enough and the pacemaker is not getting down to the portions of the ventricle that they need to, what's going to happen is the ventricle will then pick up its own autorhythmic rate. Remember I said that the ventricle's rate is very slow. Took that ventricle out and put it on the table, it would pump around 20 or 30 beats a minute very slowly. Only reason it's going 60, 70, 80 beats a minute is that it's being whipped by the node. The atria, their inherent rhythmic rate is whipping the ventricles. So what happens to that patient? Well, the first thing that happens is the patient may faint. Patient who has complete heart block or partial heart block may slow the rate so far down that the brain isn't getting enough blood or oxygen. Patient might have episodes of fainting, might have episodes of just feeling faint or weak or short of breath, and would go to see the doctor, who would see that their heart rate is actually only about 20, 30, 40 beats per minute, not enough to do the job. And we have now a rather simple cure for that called a pacemaker. Patients then have a wire placed in their heart attached to an electrical stimulator. And what happens is that is fed through usually either a vein in the arm or a vein in the leg. It's fed backwards up into the right atrium through the vena cava, which is this big vessel, and down through here under fluoroscopy and wedged against the heart muscle. The pacemaker then sends little impulses at whatever rate we want and determine, and it does the same thing the node does. But now we're bypassing this block and pacing the heart down here. Now, when I first went into medical school, these pacemakers had a fixed rate, so we made them go about 70 or 80 beats per minute, which was adequate for most people, but they could not increase their rate if they had to. The battery life was also not very long, so these pacemakers had to be changed. Today we have demand pacemakers, which have computers in them that can sense the need for increased rate and can increase their rate. They might have somebody who has an intermittent block, and when the heart is beating normally, the pacemakers don't fire. But if there's a pause, the pacemaker will fire. They have variable rates, they have very long-lived batteries, and they can do very well over many, many years and saved a lot of patients' lives and returned them to normal activity. When the patient, going back to this diagram, didn't die of a heart attack from an injury here, they could have become what is called a cardiac cripple, unable to do anything except for the advent of the pacemakers. So the conduction system is a very delicate, very finely balanced system that has a lot to do with the physiology and the timing. Now, what can happen in another aspect of this electrical system is some patients who, for example, might have valve stenosis, a tight valve. What's going to happen to an organ pushing against a tight valve? It might dilate. This valve might get big and thin-walled like an overblown balloon. Then what happens is the distance that the conduction has to go is further than normal. Not very far, but still further. And that can slow down and throw off the timing. This is another area, atrial dilatation, where the timing may be thrown off and the pacemaker may help. Let me go through now and show you the phases of the cardiac cycle, and then talk to you a little bit about how this is affected by all the timing and what's happening in the rest of the heart. The first phase, and I'm not going to get into specific pressures, but we're just going to talk about high and low pressure rather than numbers. We call the first phase the phase of relaxation. Nothing is pumping. It's a split second, literally a split second, where the atria on both sides and the ventricles on both sides are in complete relaxation. So we actually have atrial and ventricular diastole. Blood comes in now, coming back from the body or back from the lungs, body on this side, lungs on this side, come back into the atria, and then will pour into the ventricle through the mitral and the tricuspid valves by gravity, by suction, and passively fill the ventricles. At the end of that portion of the cycle, the atria give its final little squeeze to push that last 30% into the ventricles and fill them up. And as we said, that's the part that's kind of optional, just a matter of efficiency. There's a law now that comes into place called Starling's Law, sometimes called Frank-Starling's Law, to give somebody else credit, which tells us that muscular contraction and its power is very dependent upon stretching. So if you have muscle that's at a normal length, just resting, it can contract with certain power. If you stretch it a little bit, it's like stretching a rubber band. It can contract with more power. And just like a rubber band, if you stretch it too much, it'll overstretch and lose power again. There's a place on that curve where you get to the maximum power in Starling's Law, and that's just what the ventricles do. Looking back again now, so this ventricle and this ventricle like that extra little squirt of 30% of the blood to overstretch these muscles and allow a more powerful, efficient ejection of blood. That's Starling's Law, and that brings us back to the bundle of His and the slowing down of the conduction to allow a pause so the atria can contract before the ventricles do. In the next phase of ventricular filling and cardiac cycle, the valves are open at this point because blood is still flowing through. We have atrial contraction, which in this case is called atrial systole, but we usually don't talk about it. And then we are approaching the point where the valves are still open. These valves, the aortic and the pulmonic valves, are now opening because of contraction, and ventricular systole starts. Both sides, both together, ventricles contract, and both these valves open to allow the blood to go out the pulmonic and aortic valves. This is the very beginning of the third stage. What happens to these valves? Well, there's clearly going to be back pressure here and here as the ventricle contracts, because this valve is open, the pulmonic, the aortic valve is opened, but hemodynamics and pressure changes are going to close this valve and this valve, allowing no reflux, no regurgitation back into the atria. In patients who have regurgitation, for example, women I mentioned and some men with mitral insufficiency, a prolapsed mitral valve, this little leaflet right here might flop back. Or remember the chordae tendineae, the little tendons that held it? One of those might rupture and allow it to flop back. That would just decrease the efficiency of the whole ejection. So now you have the ejection phase. Blood is going out into the circulation, feeding the brain and the legs and the arms and all the organs. And blood is also going out here to the lungs for reoxygenation and for getting rid of waste materials. We'll talk more about that in the respiratory side of things. When we have completion of this cycle, it all starts again. The ventricles relax, blood comes back into the atria, and the whole cycle begins. And we have pressures changing constantly. High pressure in the two ventricles with low pressure in the atria. When the atria are contracting, the ventricles are relaxing, and they're trying to get the maximum filling. Now, here we have a very interesting problem going on, and that has to do with the coronary arteries and what's called diastole. If you remember, in our last slide, we had two little arteries coming off the right and left side of the aorta to fill and feed the myocardium. These were called the coronary arteries. Think about what's happening. At this point, the muscle, this very strong muscle of the ventricle and some of the strong muscles on the right side of the heart as well are in tight constriction. They're pumping as hard as they can. The vessels that are trying to give them blood flow are being squeezed shut. The coronary vessels, which are feeding this very hungry myocardium, can't get any blood in. So during systole, when the whole body is getting blood and all the blood is pumping out to all the organs that need it, heart isn't getting any. The only time the heart can get its blood to its muscle is during diastole, during the rest phase. When the myocardium relaxes, there's still a pressure gradient in the aorta. Remember, your blood pressure doesn't drop to zero between strokes. It drops down to about, let's say, 70 millimeters of mercury from an output of 120. So there's still plenty of pressure to feed the heart. That's when the heart gets its blood supply. This immediately brings up a problem. The ventricular systole is a very short period of time. Let's say it's a quarter of a second, if your heart rate is 1 per second. 60 per minute or 1 per second. Diastole will be 3/4 of a second. Nice, easy time to fill the myocardium and give it its nutrition. What happens when you raise your heart rate, double, triple your heart rate, get it up to 180 beats per minute? Well, you only have 1/3 of a second for the entire cycle to take place. Systole, ventricular systole, cannot increase very much. It's already so efficient, so powerful, and so fast that there's no margin for it to increase. The entire reduction in the time is going to come out of diastole. The patient is going to lose the amount of time that the heart has to get its nourishment. No problem, normally. If we have a normal heart, I can get my heart rate up to 160, 180 in an exercise treadmill with no problems at all. I won't feel any chest pain. If you took an EKG, there would not be any changes showing that the heart wasn't getting its normal amount of blood. However, suppose you had narrowing of a coronary vessel. Suppose one of those main vessels to the heart, which we've looked at, is narrowed now 70%. Walk around to the grocery store, it's fine. Sit in a chair, it's fine. But cut down diastole, and it may not be fine. It may not be enough to feed the myocardium. We are not looking to find patients who have chest pain during this period of time. Those patients are going to come to us anyway. They're going to get up and walk too fast, climb stairs, get excited, have chest pain, may have arm pain, sweating, drop in blood pressure. We're going to see them right away. and we're going to do some of the things I'll tell you about later to maybe help them if we can. The patient we'd really like to find is the person who's going to have a heart attack, the one who has no symptoms, the one who's narrowed the vessels just enough so they get along fine, and maybe even on exercise they do okay. That's the person we may find dead on the floor next to the exercise bike or out on the road lying by the side of the road because they didn't know they had trouble. They were asymptomatic. That's the patient we would love to pick out because that's the patient we can help the most. If we can tell who that patient is, then we can do a lot to help them not get into that situation and do some of the repairs that have become so popular. How can we do that? This is one of the most beautiful parts where physiology and anatomy and clinical practice come together. First thing you can do is an ordinary treadmill exercise stress test. You put the patient on a treadmill, which is just an exercise machine. Patient is wired like an astronaut. Patient has EKG monitors strapped to the chest, blood pressure cuff, an IV going, and is placed in a room with a cardiologist and a technician, lots of emergency equipment, defibrillators, medications. And we start the patient walking at a leisurely rate. And then every so many minutes, on a very set and fixed schedule, we increase the rate of speed and we monitor heart rate and blood pressure, both of which should go up in a normal person. Then eventually we get to the point where the patient may not be able to walk or run any faster. We can actually start elevating the treadmill, and we get different levels from 1 through 7 that are clearly defined as to speed and elevation and so on. Some of these patients who have serious disease will immediately start telling you, I have chest pain, my arm's hurting, they sweat, their blood pressure may get out of order, either too high or too low, and the test is immediately stopped. That's a positive stress test. It may take later. It may take a much longer time till the patient tells you they're having trouble, or they may not develop symptoms, but they might develop EKG changes, which I'll tell you about in a few minutes, that tell us they're having a problem, that the heart is not getting enough blood during diastole. But it's got even more sophisticated than that. It's gotten to be where we can really pick out patients who may have negative stress tests. In other words, nothing shows up on the treadmill, but we can see something in their heart. What we do is something called a thallium stress test, which is actually now even being replaced by something more refined. Thallium is an isotope, a radioactive isotope, that selectively is taken up by the myocardial muscle. Here's what we do. We can see this isotope using a very sophisticated Geiger counter, and it can give us an image in color of where the blood flow is to the heart. We can see bright yellow and bright reds for good blood flow and pale blues. The computer is just told to label them that way so we can see them, where there's no blood flow. And we get the patient on the exercise platform, whatever way we're going to use it. And we do the stress part first. We don't inject any thallium. We have the patient get going and get up there until they tell you, now with no symptoms, I can only make it about another minute. They're puffing, they're sweating, they're really going, the heart rate's up around 160, they're not feeling pain, the EKG is fine, and the patient finally gasps, yeah, I can do this for a minute, but that's about it. Then you inject the thallium intravenously. It rapidly circulates throughout the body, and it ends up being taken in the myocardium everywhere there's blood flow. It won't be taken up where there's no blood flow. So it's going to find the good areas of the heart, and it's going to not be there in the bad areas. Patient then comes off the treadmill, and we let the patient rest, because the thallium will stay there for a very long time, many hours. This is why we have to do it backwards. The patient now rests for 4 hours, and we do another scan. At this point, the blood will now go back to the places that may have been constricted during exercise, and we can see what was normal, because we have to compare before and after. Here's what a thallium stress test will look like in somebody who's got a problem. This is a patient who had no symptoms and went on the treadmill and got his thallium injection. This is the rest picture. Now, what this is a horizontal slice through the heart taken by the Geiger counter. It is really only showing you the left ventricle. So if you can picture the cone shape of the left ventricle being sliced across, This is the ventricle itself where the blood is. This is the myocardium. It's very thick. We don't see the right side here. The reason we don't see the right side is it takes up so much less thallium that we just don't get a good picture in comparison because there's not that much muscle. Now, before exercise, it would look like this. In this case, of course, we've done it after the exercise when the patient's rested. But this is your resting thallium stress test showing good flow everywhere in the heart. The blue areas are the very edge of the heart, which doesn't have a big blood supply. That's really epicardium. There's endocardium. No thallium visible in the blood itself here because it's all in the heart at this point. Look what happened to this patient during stress. This patient has a whole area of his heart which is not showing any blood flow at all. This is during that very short diastole, but the patient had no symptoms. This is a positive stress test. This patient is a very good candidate now to have an arteriogram. We can take dye and run it through the heart and see exactly which vessel is involved, although the thallium stress test will tell us by what part of the heart it is. What vessel will confirm it by doing an angiogram, an arteriogram to the heart, in which, again, a catheter is threaded up through one of the vessels, again, from the leg of the arm. And this time it's threaded up through an artery. And it goes back up through the aorta and is pushed into the coronary vessels selectively, and dye is injected. We can see if there's inflow, we can see where it's blocked, and then if there's outflow from another vessel, we can sometimes bypass that block. That's a coronary bypass operation. And this is how we find the patients we can probably help the most. So that's the stress test, and that is a test that, while not perfect, any test we do is not necessarily perfect, gives a very good indication of the asymptomatic patient who might be very well helped by some kind of intervention before they get in trouble, before they knock off some heart muscle that may or may not kill them, and before they lose a lot of function. There's a lot of debate today whether this actually prolongs the total lifespan of the patient or whether it gives them a total lifespan that may be nearly the same but is improved, where the patient can do things and is not crippled by the heart pain, chest pain, and inability to function at higher levels. That debate will be resolved someday, but is not resolved yet. Let me talk now about cardiac output, because we've talked a lot about different aspects of the cardiac cycle, how much blood is being poured out into the body, and how it's affected by different physiologic aspects of what happens. This slide shows you what's called cardiac output. We are measuring the amount of left-sided blood that is pumped out to the body. We measure this in milliliters or cubic centimeters per minute. That output, if you look at the math here, and it's not really very hard math, is the stroke volume, which is the amount of blood that ventricle will push out in one beat, right there, milliliters per stroke, times the heart rate, which is strokes per minute. As you can see, the strokes are going to cancel when you divide them, and you're going to end up with milliliters per minute. So the cardiac output measured in milliliters per minute. At rest, sitting here at this table, a normal person might have a heart rate of around 70 milliliters. Will have an output of 70 milliliters per stroke. If their heart rate is somewhere around 75 strokes per minute, that'll be approximately 5 liters or close to 5 quarts of blood per minute. An athlete, not a very well-trained athlete, but an ordinary person might get on a treadmill or be playing some tennis and get their cardiac output doubled from 70 to 140 milliliters per minute times a doubled stroke per minute rate, and end up with 21,000 milliliters per minute of volume. So by just doubling each of these two parameters, we quadruple the amount of output. Now, it's not unusual for a young, healthy athlete who is well trained to actually go out and get heart rates up closer to 200 beats per minute and volumes of closer to 200 milliliters or so per stroke volume, and therefore get into enormous cardiac outputs that are far in excess of an older person. We also have heart rate considerations. You probably have all seen the charts they have in exercise clubs and walls about your maximum heart rate. A young, healthy person can get up into normal, non-dangerous heart rates of 200 beats per minute, no problem. There are pathologic states called arrhythmias, which get up to 300 beats a minute. Those are dangerous. We have to stop those from happening. But as we get older, our ability to get that rate up at all slowly decreases with time. It's almost a straight line. One of the rules of thumb for a safe cardiac rate, maximum rate, is to take the number 220 and subtract your age. So if you were 60 years old and you subtracted that from 220, you probably shouldn't be pushing your heart rate in exercise over 160, and probably should take 80% of that for safe exercise levels. That's what you see on the walls of all the gyms. That's where this comes from. Now, this doesn't say that a 60-year-old man or woman in good shape and good heart couldn't push up to 180 or 185. The heart might do it, and it might do it safely. These are just guidelines to keep you on the safe side. It probably is no advantage to conditioning to push beyond these kind of levels. Let's talk now about something you've all seen and actually may have been bewildered by many times, and that's the electrocardiogram. I don't know of many people who get beyond a very old age without having had one of these taken. It's called an EKG because it comes from the German word for cardiogram, sometimes called an ECG. And this is a picture of the electrical activity of the heart, and that's all it is. It's just a picture of the electrical changes that are going on during the heart cycle. Leads are placed all across the chest. Sometimes they're placed on the hands and the feet. And it's like taking a picture of something from different points of view. In other words, the two electrodes on your leg are seeing electrical impulses as they come off the heart, being transmitted through tissues and picked up in the legs. You can see them on the chest. You can see them in the hands. You can take this picture from wherever it gives you the best view. If you want to take a picture of my gradually enlarging bald spot, we'd be better off having a camera behind me. But right now, that's hidden. And we use the electrocardiograph, different leads to see different pictures. But essentially, all the pictures are giving us the same amount of electrical function, just viewed from a different place. The one I have up here on the screen is a very, very common lead. And this is one heartbeat. It starts off with a graph. The axis of this graph, what's called the x-axis, is time in seconds. And you can see here that this is less than 1 second, 0.8, from beginning to end. And so that means this patient would have a heart rate of about 70, normal resting heart rate. This is amplitude. Here's 0. And we can have negative and positive electrical charges, so that's what this is measuring. We have time and amplitude. In the very beginning, the first thing we see is something called the P wave, and these are just named after letters of the alphabet. They could have been X, Y, Z as well. Arbitrarily, we call this the P wave. This is the electrical picture of atrial depolarization, meaning the electrical impulse to contract the atrium has begun. It doesn't mean the atria has begun to contract. This happens about 1/10 of a second later, because first you have to have the impulse and the muscle has to respond to it. So we're seeing atrial depolarization here, and the atrium contracting is probably going to happen somewhere in here. The next thing we see is called a QRS complex. We see a negative Q, big high potential spike to R, and then down below the baseline to S, and then it comes back. This marks the beginning of ventricular systole electrically. It's not the contraction yet, It is the electrical impulse, and of course, the actual contraction will happen later. Why don't we see any electrical contraction in here for the atrium? This is when it's occurring, or we might see repolarization, where it's getting its electricity back again. The reason we don't see it, it's buried in this electricity. This is just so much electricity dominated by the ventricles that the little atria just gets buried in there and we don't see it. The next thing we look at is something called the T wave, right there. And that's when the ventricle is repolarizing. It's getting its electricity back again, getting ready for the next beat. So we see pretty much everything here for the ventricles. We don't see atrial recovery electrically because it's buried. And we measure these very carefully. The doctors and now computers measure these to fractions of a millisecond, and we look for normal length. There's a PR interval, the length of time between the beginning of the atrial contraction to the beginning of the ventricular contraction. We talked about heart block. What would happen in heart block? We'd have a prolonged PR interval because it would take longer for this impulse to get to the ventricle for it to contract. That's a diagnosis right there of heart block. You can actually have complete dissociation. If you have complete heart block, you'd see a bunch of P waves and you'd see a bunch of QRS complexes, and they wouldn't be coordinated. They'd be each doing their own thing. That's AV dissociation, atrial ventricular dissociation, something that can be rather serious. We can see big depressions in the Q wave. We can see big depressions in the S wave, and they all signal different types of pathology in the heart. You can see an elevation of the ST segment in heart attacks. Sometimes that happens early on. You can see the T wave flip upside down. That can be caused by other areas of the heart being damaged, or something called ischemia, meaning lack of blood flow. There's a whole diagnostic range of possibilities when you read an EKG. And EKG has been and remains one of our very best diagnostic tools. Doesn't tell us everything, but it tells us a great deal about what's happening in the heart. The next thing I want to talk to you about is the sounds that the heart makes. This is something probably most people are more familiar with than anything else about the heart. We're used to, I'm sure when we're all children, the doctor told us that your heart goes lub-lub or lub-dub or thub-thub. And we used to have arguments with a 3-year-old friend of mine about whether it actually went lub-dub or thub-thub, because her doctor told her one thing and her mother's doctor told her another. In any case, they make muted sounds, and those sounds are not the sounds of valves slamming shut. The valves are soft, they're silky, they're delicate, they don't make any noise. It's the sound of turbulence as the valve slams shut and the blood near it becomes turbulent. You don't hear a splash because you need air for a splash. You can't run your hands fast or clap underwater and get a splash. You need to be in contact near the surface where there's air. But you do hear turbulence. You're hearing the turbulence of the sound against the wall and against the valve itself. So if we look at this slide, what we're going to hear when these two valves slam shut, the mitral and the tricuspid, we're going to hear one sound. This is the sound that occurs during ventricular systole. It's the lub. What we hear is the contraction, the turbulence, and it goes lub, and immediately after we hear the dub, which is the sound of these valves are now relaxed, and a split second later, the aortic valve and the pulmonic valve closes. They're alternating, and we're hearing lub-dub, lub-dub, lub-dub. because what's happening at the end of that is diastole. We're hearing the two sounds marking systole and then the pause for diastole. So you don't hear a steady bup, 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 bup. You hear bup, 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 bup. Even as it gets faster and faster, you still maintain that rhythm. Now, pressures are changing all the time, and I think you can figure out what those pressures will be. The mitral and the tricuspid valves occur together. That's why we hear only one sound. It's called S1, the first sound, by our definition. And then when they relax, you hear the pulmonic and the aortic valves making their noise, and that's the second sound. There are cases where the sounds can be split. Normally, they close exactly together. You're really hearing mostly the mitral sound. It overcomes and obscures the tricuspid sound because of pressure. Same thing in the pulmonic and aortic. You're hearing mostly aortic because it's a higher pressure system. But suppose there's something that makes them split. Suppose, for example, there is mitral stenosis. The mitral valve may take longer to open, or there is a conduction defect making this open later. Then you might hear bop, 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 bop. You can hear the two valves, the mitral and the tricuspid valve splitting their sound. That's called a split first sound. Or the same thing could happen if there's aortic stenosis. You might hear the normal mitral valve, bop, 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 bop. That's a split second sound. And you can split all four valves, and you can hear bop, 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 bop. And you can make the diagnosis just with a stethoscope. Or 100 years ago, just putting your ear to the chest of the patient and listening. It's not very sophisticated, but it actually works. Now, what can happen, there are lots of diseases that can make this happen, and there are things called gallop rhythms. Often one pair of valves is okay, the other pair of valves is not, and you'll hear bop, 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 or you'll hear bop, 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 depending on which is split, and we call them Kentucky and Tennessee gallops, because it sounds like somebody's going Kentucky, 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 or Tennessee, Tennessee, Tennessee. And the pairing of those gallops tells you what's going wrong. Different pathology, different problems with the valves cause different gallop rhythms. We also have murmurs. That's another sound you've probably heard about. If your valve isn't opening well, it's going to cause turbulent flow on the way out, not just when the valves close. So during systole, ventricular systole, what you may hear, for example, in aortic stenosis, a tight aortic valve, is psh, bop, psh, bop. The first sound will be obscured by the murmur, which starts immediately with the opening, and you'll hear psh, bop, psh, bop. Or if you hear mitral insufficiency, you might get a similar murmur at the same time, different pitch. And you can have murmurs all over the spectrum depending on where they're happening. They're called systolic murmurs, diastolic murmurs, and we hear them in different places. We actually don't hear them exactly where the valves are located. If we look at this diagram of the placement of the valves and the placement of the sounds, here are where the valves are actually located. Remember from our other picture, here's the aortic valve with the blood going out this way. Here's the pulmonic valve, blood going out this way. Here's the bicuspid or mitral valve, and here's the tricuspid valve. First of all, we don't like to listen right over the sternum. That's bone. It's in the way. We like to listen in the interspaces between the ribs where we can hear things better. And we place our stethoscope way up here where the blood is shooting out in this direction. We put our stethoscope over the area where we're going to hear the turbulence, and we hear it best. And that allows us to make the diagnosis and sometimes even separate the sounds. For example, we can hear the mitral valve here very well. Anywhere else, it'll obscure the tricuspid valve, but not here. Here we'll hear the tricuspid valve better. So we can make our diagnosis that way by knowing where we place the stethoscope and by getting an idea of what's going on with those valves. What can we do for these patients? Occasionally, we can do some things to help them out. If they have some of the problems we've talked about, very quickly, we can put a balloon into the coronary vessels. We can blow that balloon up, and we can squeeze the plaque shut, get the obstruction open. That's a coronary angioplasty, done without putting the patient to sleep, just through a vessel in the arm or leg. Today, we can put in stents, which are little wires that hold these open so they don't close. And now, in the further improvement, we actually have chemicals that seep off these stents to make the repair better and keep inflammation from occurring. And finally, we can do bypass grafts where we jump right off the aorta with an artificial graft, either a vein or a woven Dacron, and go past an area of obstruction into the coronary vessels. This is all very aggressive, very scientific and technically difficult surgery. Some of it's actually rather easy, easier than you would suspect. But we do give patients a much better lease on certainly their activity, if not their longevity. And these procedures have become less invasive with time. As I said, the coronary bypass surgery is an open chest operation done on bypass pumps, which is a very, very big deal, as opposed to percutaneous, meaning going through the skin, into vessel, transluminal angioplasty, and placement of stents. This has been a remarkable improvement.